Evening, and thank you, Thomas, for inviting me to be here tonight and for the opportunity to deliver the Center on Aging and Health's annual Distinguished Lecture. I want to begin by congratulating Crystal Spooner and the Orange Street Village, the winner of the annual Center on Aging and Health Innovation Award. Awards like this are so important because I think we have a narrative about healthcare in Canada where we like to kind of imply that it's behind the times and not particularly innovative. And it's critically important to highlight all of the ways that we are doing well and doing good in our systems across the country. You know, I've only been here in Regina for about 24 hours, less than 24 hours, and I have to say I have a strong sense of innovation all around me. I've learned about Thomas's work that relates to better identifying and managing pain for older adults and for people living with dementia, work that's been taken up already by more than 20 countries around the world. I've learned about the Seniors House Calls program here in Regina that's reducing emergency department visits, that sends nurses and nurse practitioners into seniors' homes and paramedics into the homes of frail people so that they don't have to come to the emergency department when they're not well. And of course, I got to taste the butter tarts at Orange Street Village. So there is amazing innovation all over Regina, and I'm going to go back to Toronto and report on all of that. One of the amazing things about having gone through this experience that I'm going to speak to you about tonight of publishing a book and traveling across the country is that people want you to see their innovations, right? They want you to see all of the great work that they're doing locally, and there is so much outstanding stuff happening across the country in the healthcare system and beyond. And it's left me with a lot to think about because on the one hand, there are these extraordinary projects here in Saskatchewan and everywhere all over Canada that are about improving the quality of care that we're giving to seniors and to people more broadly and improving their quality of life. But what if you don't happen to live in Regina? What if you're struggling to get access to healthcare in rural Saskatchewan or in downtown Halifax? How are the local innovations that we are celebrating here tonight going to help you if you don't happen to have the good fortune to be able to access them in your local community? This is the problem, the central problem of the Canadian healthcare system. It's that we have so much innovation and outstanding work going on, and yet we fail to scale it up across the country. And that's a problem that I discuss in the book and that I want to talk to you about tonight, that failure to spread and scale success so that every Canadian who deserves it can access that kind of successful, innovative project. Now, this matters for a lot of reasons, not the least of which is because Canadians really do view our healthcare system as one of our most important assets. And you are evidence of that tonight, right? You're cheering for me like you're watching a hockey game, right? Like it is this sort of, it does touch a nerve for Canadians, this conversation about our healthcare system, particularly when it goes south of the border. And so clearly that healthcare system has taken on symbolism that extends far beyond just, you know, an insurance plan or a set of service delivery mechanisms. It has come to symbolize something to do with who we are as a country. But like any asset, after 52 years, Medicare needs some updating and some upgrading. And while it was a prior generation that established this important public asset, fighting for that basic value that access to health care should be based on need, not ability to pay, it's going to fall to us to renew it for the 21st century, or as I like to say, to make Medicare better now. So if you haven't noticed already from Thomas's kind plug and the stack of books on the table outside, which you should feel free to pick up on your way out, Better Now is the name of this book that I released last year. And the intention in that project was very particular. It was to use stories, the stories of my own patients as a family physician working in the system, the stories of my colleagues when we sit around and talk about the things that we face in our jobs every day that give us pause, the stories of my own family to describe the tremendous opportunities ahead for Canadian healthcare. And so I want to begin tonight with the story of my family. Because if you've read my book, or heard me speak, you know that when I take the microphone to talk about healthcare, I'm not just talking as a doctor or a hospital administrator. I'm speaking as a daughter, as a granddaughter, as a person, as a parent, from a place that is deeply personal. And so the opening of my book shares this experience. In 1951, my grandparents, Jacques and Sarah, arrived at Pier 21 in Halifax. They had a family of 3 generations that had come on a big ship from Cairo to start a new life. And they had left behind, like so many of us and our ancestors have had to do, they had left behind almost everything and everyone they knew. And as my mom tells the story, because you can imagine what it's like to arrive in Halifax in December from Egypt, the snowdrifts were so high that they towered over her. She remembered them as mountains. She was 3 or 4 years old at the time. And they had basically brought with them a couple $100 and several trunks of totally inappropriate clothing. And they took the overnight train to Montreal. And the job of making this new life work in a new country principally fell to Jacques, who was a very accomplished man in his early 40s. He was a talented musician. He spoke 7 languages, big, broad-shouldered guy who let off an air of authority. And he was ready to take on this challenge of building a new life for his family in a new country. Until a year later, when at the age of 41, a year younger than I am now, he suddenly and unexpectedly suffered a massive heart attack and landed in the hospital for more than 2 months, as we used to do in those days. That ordeal diminished him, and as I'm sure we can all imagine, not just physically. There was the immense stress of not being able to work, which of course meant failing to support his family. And my grandmother, who at the time was working as an assistant in a Montreal ladies' dress shop selling fancy dresses to well-to-do women, was suddenly the sole income earner for this extended multi-generational crew. And the cost of the hospital stay, followed by the ongoing costs of prescription drugs and visits to the doctor, essentially became more than they could bear. My grandmother was left enduring the twin pressures of caring for an ailing husband and holding together a family that was under financial pressure. She had to borrow money from relatives that she knew she would never be able to pay back, and in fact that she was never able to pay back. And for reasons that are incomprehensible to me, except that I guess this is how families go, the tension between the different factions of the family exists to this day around the money that was never paid back. But she had no choice. She couldn't, and neither would any of us, deprive her husband of the medical care that he needed to survive. My grandfather would then go on to have more heart attacks, further limiting his ability to work, and eventually he basically took to his bed. And for my grandmother, she eventually succumbed to the pressure of it all and herself was admitted to hospital for 6 weeks, having suffered what was known in those days as a nervous breakdown. The stress had basically just worn her down. 15 years after he came to Canada, my grandfather died at the age of 54. And the year was 1966, the very same year that our federal government first moved to create universal health coverage in Canada, otherwise known as Medicare. So I ask in the opening of my book, and I have now asked thousands and thousands of people in talks like this across the country, how different might life have been for my grandparents and for my mother, who has carried this story like a stone her whole life? How different would life have been for them if Medicare had been in place just a generation earlier? And the answer, of course, is very clear. It would have changed everything. But that experience didn't just shape my family history, it also shaped me. Jacques and Sarah's experience of the Canadian healthcare system is what I've worked my whole professional life to try to address. The promise of Medicare in the 1960s, of course, one that started right here in Saskatchewan, was that no Canadian should ever have to go through something like that again. Canadians declared that in this country, we take care of one another, and that access to healthcare should be based on need, not ability to pay. But today, Medicare binds us together in many more ways than just by delivering health outcomes. It strengthens our economy, it improves our social stability, and it gives us an example that we can point to of what it is that our country stands for. I mean, in public poll after public poll, Canadians will point to their health insurance plans as a symbol of what it means to be Canadian. And truly, boiled down to its very simplest terms, that promise is what gets me out of bed in the morning. And it's the reason why I set out to do this book, which is not geared to the academic community or to the policy community, but to Canadians who believe in the principle of fairness of our system, but who know in their hearts, and we all know in our hearts, that it needs to be improved. So it's been more than a year now since this book came out, and I have to say the response that we just saw from the video that you watched has been brought into very sharp relief for me. And my hope is that we can somehow capitalize on that intensity and that passion to try to move forward in some of the areas where we clearly need to make the system stronger. Because, of course, there's lots that we can be proud of with our system. It is a system that delivers overall good outcomes. It's easy and inexpensive to manage from an administrative point of view. And when it works, which is not always, but is probably more often than many of us give it credit for, it provides good access to high-quality care. And, of course, we don't go bankrupt because we have a premature baby. We're not turned away from the doctor's office because we don't have the money for an appointment. And the debate that we see raging in the United States today, going on south of our border, I think has been a really energizing force for Canadians around that principle. I think many of us are totally, in some cases horrified, but often just puzzled by the conversations that we see going on in the U.S. as we watch the Congress debate, variations on variations of bills that would repeal and replace and further repeal and further replace, and ultimately that have actually taken away health coverage from millions of families across America, families who now do not have health insurance, but who had it 2 years ago and must now face the kinds of impossible choices that once confronted my grandparents. So that's great, and it's good to be proud, but we shouldn't be complacent. There are still far too many people, including right here in Saskatchewan, who struggle to obtain the health services that they need. So let's get specific, because nearly every one of us in this room knows someone whose health is deteriorating because they can't afford to pay for their prescription medicines, or they're taking their pills every other day, or they're splitting their pills in half, or they're taking them for the first 3 weeks of the month and then waiting for the next check to come in. Or for people who can't afford to see a dentist or to buy the healthy food they need to set their kids up for a decent life. Physicians like me see people waiting too long for elective appointments and procedures that should not be so hard to get organized. And we all see, as we're going to discuss tonight, seniors bouncing in and out of emergency departments and inpatient wards because there isn't adequate support for them in their homes. Those are the stories that highlight the need for change. But they also, I think, raise a bigger question that came home for me very early on. It was actually in Ottawa, one early stop on my book tour, where I went to give a talk sort of like this one. And at the end of the talk, a group of about 6 women came up to speak to me. And they had copies of the book under their arms, and there were little sticky notes sticking out of them, like areas that they had folded down that they wanted to discuss. This was a book club of retired nurses. It was the greatest moment. And they were coming to say, first of all, they had stories of their own that they wanted to share about their own years of experience of working in the healthcare system and treating people who required help, and all of the ways that they had seen the system both succeed and fail for those patients. And they had their own ideas. The most common thing I get since I came out with this 6 big ideas thing is, you should have had a 7th. And the 7th should be, ... And everybody's got their idea, which is exactly perfect. That's as it should be. Notions large and small about what we should be doing to strengthen the system. But these nurses had something more. They had a question. And the question has dogged me now for a year, everywhere I've gone, and with nearly everyone I've addressed. It was a very simple question. They said, "We've read your book. We agree with your ideas. What can we do?" They were tired of talk. They were fatigued by analysis. They were looking to take action. They wanted to know, how can we help? What are you asking of us? What button can we click? What petition can we sign? What call can we make? What can we do differently with our own families and in our own communities to contribute to seeing these ideas implemented? Not as nurses, but as citizens. What can we do? And by that they meant specific. What can we do right now? And what can we do that will make a real and lasting difference? They wanted to take action. Well, of course, there are many answers to that question. Some of them I'm sure you'll be better at coming up with than I will, because at the end of the day, I'm not running for office or running a political campaign. I don't have anything you can donate to or anything that you can sign in particular. What I'm trying to do is to get enough people energized about these ideas that we can collectively start to push for action. But I want to talk a little bit tonight about what we can do with respect to seniors, because that, of course, is our focus this evening. And in order to do that, I need to tell you about a person who I talk about in the book, a woman who I call Susan. Susan is a 75-year-old widow who lives alone in a community in Saskatchewan. Her kids moved to the big city for work, so she's on her own, but she's got lots of friends in the neighborhood, and she's got an active social life. And as each decade has passed, as will happen to both the seniors and, as I say, those of us who aspire to someday become seniors, as each decade has passed, she's accumulated another diagnosis. Diabetes in her 50s, lung disease in her mid-60s from having smoked in her youth, a heart attack at the age of 72, followed by bypass surgery, and osteoporosis on her 74th birthday. Like so many Canadian seniors, Susan takes 8 different medications, sees 3 different specialists, and needs to be totally on top of a wide number of elements of her own care. Now, here in Saskatchewan, where the income requirement for prescription drug coverage for seniors has become more stringent, Susan, with those 8 medications, might feel pressed, as do the roughly 6,000 other seniors who've lost their prescription drug coverage in this province in recent years. Not only is it difficult to manage complex chronic conditions on your own, the financial pressure of uncertain drug coverage is something that needs to be fixed in short order, and that's something that I'll come back to. But let's return to Susan, who one winter develops a cold. She's actually feeling quite unwell, and she has a hard time eating and drinking. After a few days, she starts to feel weak, so she decides to see her family doctor. She calls the office, but there's a message on the machine. He's gone to Florida for a couple of weeks. And Susan doesn't want to bother anybody, so she decides to tough it out. Until a couple of days later, she really starts to feel terrible, and so she breaks down and visits the emergency department and actually is admitted to the hospital because she's dehydrated. While in the hospital, she has trouble sleeping in a strange bed, and so she's prescribed a sleeping pill by the doctor on call that night. Susan ends up becoming confused and groggy as a result of the medication, and when she gets up in the middle of the night to pee, you know what happens now. She falls and she breaks her hip. 2 days later, she has surgery to fix her hip. 2 days, by the way, where she's been lying in bed getting progressively weaker and less likely to be able to return to her own home. She has the surgery, and post-operatively, her blood pressure is low, so the doctor helpfully stops her blood pressure medications. But she leaves the hospital without a prescription to restart the medication, and she doesn't know what to tell her family doctor about what she's taking and doesn't take. And the family doctor is going to get, something in the snail mail 3 months from now saying that things were changed while she was in the hospital. So he doesn't click into the fact that she's not taking her blood pressure pills. And this is probably what contributes to her second heart attack. The ensuing months consist of a series of hospital admissions and several weeks in the ICU before Susan eventually dies. So it doesn't have to be this way. Right? I mean, I see that, and I know that you see it too. If Susan's family doctor or a nurse practitioner on his team had been available when she first got sick, I'm not saying the guy's never allowed to take a vacation, but if somebody could have seen her, if he had had the information about what happened to her while she was in the hospital and the changes that had been made to her medications so that he could have figured out what was happening and restarted them, if her 8 medications had been covered in the first place so that she didn't have to choose between groceries and prescriptions, if she had been asked what her goals were for her care when she became increasingly frail, if she had been offered the option to die at home, this could have been a very different story. The good news is that fragmented care and access to life-saving prescription drugs are things that we can fix without actually spending a lot more money. In fact, often by spending less money, but spending it differently. By better organizing primary care in our communities, by changing the ways that we communicate across the different parts of the healthcare system, by organizing home care services that meet the needs of the aging population, and by covering essential prescription drugs for all Canadians, we could do better for the thousands, indeed millions of Susans across the country, and it would probably cost us less than what we already spend. I'm going to pause for a moment here on prescription drug coverage because it's been a busy 72 hours on this file in Canada. There was an announcement, for those of you who missed it in the federal budget, that there will be an advisory council on the implementation of Pharmacare that will be chaired by the former Minister of Health in my own jurisdiction, Dr. Eric Hoskins. It's not clear to me at all what it means or what the intended plan is there, but the evidence is very clear that if we were to band together on national Pharmacare, Canada could save at least $4 billion every single year because we would be able to start paying the kinds of prices that other developed countries pay for their drugs. If done right, a program like that would help so many seniors, both here in Saskatchewan and beyond. But of course, drug coverage isn't the only thing that Susan needed. On the care, redesign, and delivery front, several of the big ideas that I've talked about in the book and in the last year on the road would have dramatically improved her care. The first, what I call Big Idea 1, is the need for relationship-based primary care for every single Canadian. Nobody expects, as I said, for Susan's family doctor to be available 24 hours a day, 7 days a week, but group-based models of care and networks of various kinds, including teams that have nurses and nurse practitioners and physician assistants and pharmacists and dietitians and other kinds of healthcare providers, not just doctors, those kinds of teams are increasingly the norm. And such a team could have made a really big difference for Susan. And then there's the need to protect people from people like me, the harmful, unnecessary, and inappropriate medical tests and treatments that are becoming increasingly more prominent, not just in Canadian healthcare, but around the world. And which is why I talk about in Big Idea 3 this notion that I call, don't just do something, stand there. Because actually, in many cases, we cause much more harm than good. And I think we can all agree that Susan didn't suffer from a lack of health care. I mean, this is a person who, by any measure, probably got more health care than any of us would ever want for ourselves or for our loved ones. And there are some very concrete things that each of us can do if you're a healthcare provider in your own practice and also as patients and family members of patients to try to protect yourselves from the harms of unnecessary and harmful tests and procedures. There's a campaign some of you may have heard of called Choosing Wisely Canada that has a list of 4 questions you can ask your doctor or your healthcare provider when a test or a treatment is in the offing. They include, do I really need this test, treatment, or procedure? What are the downsides? Are there simpler or safer options? And, revolution, what happens if I do nothing? Because, of course, very often the answer to that is probably nothing happens. Maybe you get better on your own. Maybe we could have this conversation again in a week or 2. And then there is the issue of how to reorganize our healthcare services to be less centered on hospitals and more community-based. One of the fallacies that I address in the book, and I have to say this is a fallacy that unfortunately is often reinforced by groups of healthcare providers in the system, including doctors like me, is the fallacy that when people experience poor care in our system, particularly with respect to wait times, the solution must be more. More doctors, more MRI machines, more nurses, more hospital beds. Surely if we spent more money, these problems would be solved. Of course, there are some places in the system where investments are needed, but nearly always we could be doing so much better with the resources we already have. Putting more money or more personnel or more machines into the same systems that we have in place today would not have yielded something better for Susan, who ultimately suffered not from insufficient care, but from care that was poorly organized. In the book, I talk in depth about what that reorganization needs to yield, including more services in the home, better end-of-life care, which is a conversation we should not be afraid to have in this country, and better organization of specialty resources to reduce wait times. And one of the examples I like to point to is a program in BC called RACE. I know you also have a RACE program in Saskatchewan, but it stands for some different acronym. RACE in BC is a telephone line where any family physician or primary care provider who's seeing a patient in the office can call, and I think there are now 52 specialties, maybe more, participating in this. And it's sort of like press 1 for cardiology, press 2 for gastroenterology, press 3 for neurosurgery. And you know what happens when you press 3? A specialist answers your call. It's like a revolution if you're a family physician. It's an extraordinary thing. They answer your call, and their job is to help you figure out what you need to do for your patient. And guess what? Huge numbers of people no longer need to be referred to a specialist and sit on a wait list for 3 months, because it's the kind of thing that a simple 5-minute conversation between 2 skilled professionals, you can sort things out and make an action plan. That's an example of actually using the resources that you have more intelligently rather than needing to train, a neurosurgeon for every single community in the country. All of these things need doing. And I know that many are underway here in Saskatchewan as you reorganize your health regions and think differently about the services that you're delivering. Sometimes Canada is very fond of these structural changes. I've been watching it happen all over the country, as have others, in Alberta and in Saskatchewan and in Nova Scotia. It's like there's 12, and then there's 1, and then there's 4, and then there's 3 health authorities. But every time you reorganize these structures, it's an opportunity to think differently about the kinds of services that you're providing and the way that you're organizing them, and not just for Regina, but in particular for your rural communities. So I want to return now to the very first issue I raised, because there are some issues that you can't actually address locally, that no single province or territory can address on their own. And this is one of them, the fact that right now, today, 1 in 5 Canadian households reports that someone in that household is not taking their prescription medicines because of concerns about cost. And this is not a problem that is going to get any better, because the days where stable employment, where you had good benefits and a pension that was going to last you to the end of your working days, are gone. And part-time employment is on the rise, contract and precarious work is on the rise. And we're only going to see the rise of people who are living either without drug coverage or with intermittent drug coverage over the course of their careers. And it's not only low-income families. It's not just the nannies and the taxi drivers of our country. There are high-paid consultants all over this country who are self-employed and who are one diagnosis away from catastrophic drug costs. That is something we can actually do something about. It is something that we should do something about. And I have decided that at least for the next 6 months, that is the answer to the question that the Nurses Book Club asked me. What can we do now? We can take on universal pharmacare. We can complete the great unfinished task of Medicare, and now, some 50 years later, lift the burden of drug costs from the shoulders of those who can least afford to bear them: individuals, families, small businesses, and even large corporations that are in no position to try to negotiate with multinational drug companies on the prices of drugs. It's practical, it's possible, and it speaks to the same principles that inspired my grandparents' generation to institute Medicare in the first place. So to all those of you who wonder, what can we do and how can we help, I say we can do this. As a matter of public finance, as a matter of public policy, as a matter of public decency, universal pharmacare is a cause to which we can all commit ourselves. So all those of us who are in this room tonight have tremendous power, both individually and collectively, to shape what happens in this community and in communities across the country. You are all part of networks of some kind. You all have friends all over the country that you communicate with, on the Book of Faces and various other things. So you could do something, but there is nothing stopping any of you from doing something about it. You could stand with me and the millions of other doctors and nurses and patients and citizens who understand the need for a modern healthcare system that doesn't abandon people when they set foot on the sidewalk outside the hospital with a prescription in their hand. There are a lot of us out there working right now to try to make Pharmacare a dominant issue in our next federal election. And I should say that this is not a partisan issue. It's a Canadian issue that crosses the entirety of the political spectrum. So tomorrow morning, you can pick up your phone. I said this to the group of seniors I met with just before this. You can pick up your phone and you can start calling your member of Parliament's office. And you can call your MLA's office. And you can call the offices of the candidates who are going to be running in your area for the other parties. And you can call them, by the way, every day between now and Election Day. They will be happy to hear from you because it is their job to listen to what their constituents and their voters care about. And you can tell them that you will be watching and listening to hear what they have to say about Pharmacare. Not just a little program that will close the gaps between employer-based plans, but a true national Pharmacare program that will cover everyone and that will reduce the high rates of inappropriate prescribing that we see all across the country. If we get enough people making that case, then mark my words, we are suddenly going to have a country full of politicians very interested in moving forward with universal drug coverage. So that's the path, right? It's not a clear unidirectional line, but that is the path to progress. And when we're done with that big idea, I have 5 more we can get started on. From relationship-based primary care for every single Canadian to reducing wait times by reorganizing the ways we deliver care, there is so much that we can do to make our system more worthy of that immense pride that we have in it, more responsive to the needs of seniors and all those of us who aspire to become seniors. And if you don't think it's possible, if you don't think that big change can happen, I would ask you to remember the story I began with this evening. I am certain that my grandmother Sarah could never have imagined that her granddaughter would become a doctor and that I would never have to ask a patient for money before treating them. But the people of this country and of this province made Medicare happen. Surely in our time, it is possible for us to renew it. With our effort, with our dedication, with our passion, we can take that next step forward. We can make Medicare better and make it better now. Thank you.